You can have the best plans possible for a PE patient, but when that patient gets sick and when the rubber meets the road, sometimes it's just the exercise and planning and having the skills necessary to come up with a plan. That's what really saves you in the end.
Patients with PE span this incredibly wide spectrum from asymptomatic to super duper sick, and that state can change dynamically. These are patients where it's useful to have scoring systems so that you can get an objective measure of how sick they likely are as opposed to how sick they look. And it's also important to reevaluate these patients. They can turn on a dime. Welcome back to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your co-host, Dr. Nick Mark.
And I'm your other co-host, Dr. Cyrus Askin. Super excited to be back with you guys to resume our discussion on pulmonary embolism. Here we are with part 2.
As you recall, in part 1, we built a foundation of physiology and pathophysiology with which to understand pulmonary embolism. In this episode, we're going to build on that foundation by doing a case and talking about how we can treat PE. We'll also talk about a lot of the nuances of decision-making and a lot of the stumbling blocks where people struggle.
That's right, Nick. This is going to be another fun, jam-packed episode. We're really excited to bring it to you. I'm really excited to talk more about PE, and hopefully our audience will appreciate some of our treatment pearls.
Yeah, me too. Let's jump into it.
All right, folks. So in part 1 of this 2-part series on PE, we talked about pathophysiology, physiology, diagnosis, some imaging modalities that we would use, et cetera, et cetera. Now, for this portion of the discussion, we're going to focus on a case, like Nick said. And so this is a case of a patient we might actually encounter in the ICU, and we're going to use this case to really discuss treatment modalities and some of the nuances associated with them. So without further ado, we've got a 45-year-old previously healthy male who's admitted to the hospital after a motor vehicle collision, during which he sustained bilateral femoral fractures. In the trauma bay, he was X-fixed and then moved on to the floor where the OR team took him back for surgical fixation via ORIF. For the uninitiated, an ORIF is an open reduction internal fixation.
That's for the people who don't speak orthopod. It's a difficult language, just like heptapod in the arrival, right?
Exactly right. Thanks, Nick. Thanks for clarifying. So anyway, this gentleman has his ORIF bilaterally. Everything goes great, and the hospitalist, given the nature of his fractures, recommends at-home DVT prophylaxis via low molecular weight heparin. About a week later, the patient unfortunately comes in short of breath and tachycardic, and he admits, "Well, I never really started the low molecular weight heparin because I was worried about bleeding, and I don't really like needles." And so here we are now in the ED where the patient is normotensive. He's got a blood pressure of 110/70, but he is noted to be tachycardic, as I'd mentioned, to 112. His oxygen saturation is 95% on room air, and he also seems to be tachypnic with a respiratory rate of about 31. Diagnostic testing reveals that he has a large occlusive pulmonary embolism in the left main pulmonary artery with evidence of RV strain on CTA. Cardiac troponin and pro-BNP are both elevated, and the EKG reveals some ST T-wave changes in leads 2 and 3, along with that tachycardia. So what do we do, Nick?
I mean, the first thing we probably ought to do is we ought to risk stratify him. We ought to figure out how sick is this guy, because when the ED calls and they tell you somebody looks good or somebody looks bad, that's an important variable, but we should also use the objective data to try to predict. And so in part 1, we talked about the ESC guidelines. This patient has RV strain and positive biomarkers ×2, so they would be considered intermediate high risk. Recall that hemodynamic instability is the hallmark of a massive or highest risk PE. The ESC defines hypotension as a systolic blood pressure less than 90 or a need for vasopressors. Others might more generally define high risk as a PE with evidence of shock, which fans of the show remember from our first episode, that you don't necessarily need to be hypotensive to be in shock. It's all about tissue perfusion. One thing that I like to do on this topic is look back across their prior visits to see what their BP normally is. 110/70 sounds normal-ish, but remember that, if his normal blood pressure is in the 140s or 150s, that's a significant drop. And some authors define shock as a 30-point drop from baseline. So it's important to think about, are these numbers normal for this patient while we're risk stratifying him?
Nick, thanks for clarifying that. Thanks for going through the ESC guidelines. I want to remind our listeners that in the United States, we typically talk about PEs in terms of massive and submassive, at least those PEs that are worrisome for our ICU folks. And so a submassive PE would be a case where you have right ventricular strain. Potentially, you also have some elevation in biomarkers versus a massive PE, which is distinguished from a submassive by way of shock. And so I think that that's a reasonable way to stratify these folks, but I tend to lean on the ESC guidelines like we discussed in the first episode, just because they're a bit more granular. And I find that the nomenclature is also a bit more patient and clinician centered, if you will. So I just want to kind of insert that for our audience that might be familiar with both of those sets of terms and be a little bit confused.
Great. Yeah. So I think thinking about what category of shock is really important, because it's going to help you decide where this person needs to go in the hospital, and it's going to help you and your colleagues decide what therapies are necessary and should be offered. Two other ways that I like to do this are to use two other scoring systems, BOVA and PESI. So the BOVA score, he's going to get points for troponelemia and tachycardia, and he's probably going to get points for RV strain. We know from the case that he had some EKG changes. He had evidence of a large RV on the CT scan. So probably once we get an echo, we're going to see evidence of RV strain. That means that he's going to have either intermediate or more likely high risk on BOVA, which corresponds to a 7 to 10% 30-day mortality rate. If we want to be more granular, we can use the PESI score, or if we want to be a little bit less, we want to do that a little bit more easily, we can do a simplified PESI score. Here, he's going to get points for his age, he's 45, his gender, he's male, the presence of tachypnea and the presence of tachycardia. This is also going to put him in high-risk buckets, which are going to correspond to a similar 4 to 11% 30-day mortality rate. So the conclusion of all of this exercise is very quickly we've identified quantitative factors about this person that should make us worried. Even if we're told this guy looks great, I want to see him for myself, and I probably am going to put this guy in at least step down and maybe ICU. And this is somebody where we need to think about doing more than just anticoagulation, just because of his high risk at the jump.
Excellent. So Nick, a couple of things I just want to double tap on. So I like that you, you use the term, consider, or we might do more than just anticoagulate them. And so that's I think very important, because in general, we're going to get into this. In general, a lot of times, even with our intermediate high risk PE patients, we'll still open with anticoagulation and kind of see how they do. But to your point, Nick, it's good to have that patient in an environment and supported in such a way that you can up the ante, if you will, if need be. I also really like the point you make about going down, seeing the patient yourself, assessing them clinically. Obviously we appreciate the initial insights from our ED colleagues, but it is very important, since you're going to be the accepting, physician in this case, you're going to be dispositioning that patient. I think it's really important to lay eyes on them and make your own, make your own assessment.
And this is a situation where, if you think about shock index, right? I mean, his heart rate is in the 110s, his blood pressure is about 110. So he's right at about 1. That's kind of a worrisome point. Those are numbers that make me a little bit nervous. It's also worth noting that a respiratory rate of 30, that might be fine for a healthy 45-year-old. He could sustain that for a while, but it's definitely not normal. And building on our conversation from last week, remember that the reason why he's hyperventilating is because he probably has a lot of dead space. And that means that he needs to have increased ventilation to maintain a normal CO2. So he's giving us some important physiologic clues that he's sick and could become a lot sicker.
All right. So on the heels of that great discussion, I think this is a perfect time to transition to our focus on treatment. And we're going to do that by discussing PE in terms of pillars of treatment. And this is to sort of borrow a term from Nick, these pillars of PE treatment, starting with number 1, correcting hypoxemia, then 2, anticoagulation, 3, optimizing hemodynamics and pulmonary vascular resistance, or PVR, and finally, number 4, thrombolysis or intervention. So we are going to talk about that, but just one other thing, I guess, before we get to that. Nick, I know you're a big fan of PERT teams. Do you want to discuss what a PERT team is for our audience?
Yeah, so I think this is sort of like the sort of like organizing principle that helps guide all of the pillars of treatment. And PERT, or PE response team, is basically a multidisciplinary protocol driven team where you can collectively decide on treatment. So at my institution, this is led by the intensivist. You also have pulmonary, which may be the same person, cardiology, interventional cardiology, and cardiothoracic surgery. And the idea is basically that these are all the people who could potentially be guiding interventions, making decisions about, does this person need thrombolysis, catheter-directed thrombolysis, clot retrieval? Does this person need surgery? Does this person need ECMO? And by putting all of those people on one Zoom call, we can very quickly have a shared mental model of what's going on with this patient and make a decision about what we're going to do now and what we're going to do if things get worse. I'm a big fan of this. The way it works practically is that anyone is encouraged to be able to call a PERT consult, which basically means that the intensivist gets a page, they look at the data, they talk to the person, and then they can very quickly, in about 5 minutes, decide whether or not to activate the PERT team. If the person is sick, and by sick I mean you make this decision based on like BOVA score, PESI score, and all those other parameters we talked about. Then you page the other people. Everyone joins on a Zoom call. We look over all the imaging together. We look at the echo together. We talk about the case, and we decide what therapies we think are appropriate, what we would offer, what we wouldn't. And the beauty of this is, in about 10, 15 minutes from when somebody calls and says, hey, I have this patient with PE that I'm worried about, we have this consensus recommendation for, okay, well, we should put this person in the ICU. We should do this. We should do that. If necessary, we can do this other thing. And that saves hours of time. And one thing that we know about PE is that delays in treatment are fatal. And so having a system in place where you can quickly organize your resources and get everyone on the same page is just hugely valuable.
But I do think, Nick, what you're describing, it makes a lot of sense. And based on my reading, there definitely seem to be some very significant patient-centered outcomes. Specifically as it relates to mortality and a significant reduction thereof. According to one study, implementing a PERT reduced mortality by 14% post-PERT versus 24% pre-PERT. So that's an unadjusted hazard ratio of 0.57 with a relative risk reduction of 43% with a P of 0.025. So it's a statistically significant improvement in mortality, which is presumably based upon the implementation of that PERT.
Yeah, we don't have any RCT level data demonstrating the value of PERTs, but I think that, a pre-post study like this is pretty compelling. One quick point I'll make. So I polled my followers on Twitter about this the other day, and I was kind of surprised so I asked, how does your institution have a PERT team? And let's just pull this up here. So 30% said yes, 61% said no. So I think there's probably a lot of room for improvement here. I think that, it would be great to see more RCT data that PERT teams save lives, but I think we have pretty good data so far. And I think at the very least, they make it a lot easier to do your job. So I don't know. I think they should be more widespread. I will end my rant here, and let's talk about oxygenation next.
Yeah, Nick, now that we've talked about PERT, you want to tell us a little bit about that first pillar of PE treatment?
Yeah. So as we talked about in part 1, severe PE often features hypoxemia that needs to be corrected. As we said, this is due to VQ mismatch. And so giving supplemental oxygen should raise your PaO2. In this patient, so his SpO2 I think was 95%. You said, so you could look at that and you could say, oh, that's normal, that's fine. I probably still would give this person oxygen because it may actually reduce their pulmonary vascular resistance a little bit. One other case that we should talk about that actually happens more than you might think is, what if somebody comes in with a SAT of like 85 and they put them on a non-rebreather and their SAT only goes up to like 89? Right? This is not what we would expect to happen, right? Remember that VQ mismatch should correct. This is not correcting. Something else is wrong here. And this is a textbook example of shunt. What we sometimes see with patients with PE who have right heart strain is they have a PFO, and the increase in right-sided pressures cause a right to left shunt to open up. At baseline, their left-sided pressures are higher than their right, so they're either not shunting or they're shunting a little bit left to right. But now when they get right heart strain from a PE, now they're having this shunt. And so it's a good thing to think about. Often you can pick this up before the echo just by looking at their response to supplemental oxygen.
Nick, thanks for bringing up that point in regards to the PFO, specifically in patients who receive supplemental oxygen and do not improve in the way that you would expect. So definitely something we should be on the lookout for. So moving on, the next pillar I think we should discuss is anticoagulation. That's number 2 on our list. Specifically, what is the anticoagulant of choice and how should you administer it? For the patients that we're going to be taking care of in the intensive care unit or potentially in a progressive care type setting, we're going to be discussing subcutaneous options versus intravenous options. And so from a subcutaneous standpoint, low molecular weight heparin and fondaparinux are supported as first-line agents in the guidelines. Specifically, they demonstrate a lower bleeding risk than heparin, or I should say unfractionated heparin that's given intravenously. Additionally, these medications are, of course, less labor intensive than a heparin drip that requires repeated coagulation assays and a lot of nursing interventions. There's also some evidence to support low molecular weight heparin with respect to it being more efficacious than unfractionated heparin when it comes to treating PE and preventing recurrence.
Part of the value of giving a big sub-Q dose of low molecular weight heparin is that the person is essentially therapeutic right away, as opposed to your typical unfractionated heparin, where you give a load and then you're infusing it, you're chasing levels, nurses are having to adjust infusion rates all the time, pharmacy is having to check up on stuff and recommend changes, and it often takes 6 to 12 hours before the person is therapeutic according to your assays. So low molecular weight gets you therapeutic much faster. It's much less work for your nurses and pharmacists to be there. And it's also great if you're worried about a patient transferring between facilities. Like, let's say that they're at some outlying hospital and they're transferring to a tertiary quaternary hospital. You really don't want to worry about that heparin drip being adjusted en route. It's much better to just know they've gotten the Lovenox, it's working.
Nick, that's an excellent point, especially because a lot of these patients will need to be transferred in certain circumstances if they need an intervention that's not available at the institution to which they present. So that's a good comment to make. Now, there are cases in which unfractionated heparin would be the preferred agent, and that's typically administered via drip, as I had mentioned. The first circumstance might be a case of renal failure. So, of course, we do worry about low molecular weight heparin levels building up in the setting of renal failure. And so if someone has significant AKI or CKD versus ESRD, then unfractionated heparin would be the way to go. The other case where historically unfractionated heparin via heparin drip has been given is in those patients for whom an intervention is being planned or an intervention is likely to occur. And we're going to talk about those interventions in a little while. But let me caveat that point by saying, here in recent years, the paradigm may be shifting a bit to where we're not even, leaning on unfractionated heparin in those cases.
Yeah, exactly.
Nick, do you want to share your experience?
Yeah, exactly. So I think, in the olden days, like maybe 5 years ago, the thinking was more like, if this person is not that sick, low molecular weight is better because it'll be therapeutic fast, it's easy, it's less nursing time, et cetera. But if somebody's really sick, you better use unfractionated heparin. That way, if you need to take them to the cath lab or the OR, you can just turn it off. There's a logic to that, but I think that's actually changing a bit. And I think it depends a little bit on your institution. So if your interventionalists and surgeons are willing to perform procedures on people after they've gotten a low molecular weight heparin dose, then low molecular weight heparin is superior to unfractionated heparin, so you should use that. So I'm lucky enough to work with interventional cardiologists and surgeons who are comfortable doing procedures after a loading dose of low molecular weight heparin. And so that has increasingly just become our standard, our default, because we think it's better. If people are going to be scared away by that and you really need to turn it off, maybe unfractionated is better. The other situation where I think unfractionated might be better is like somebody where their bleeding risk is really, really high, right? This is like somebody who had a GI bleed like last week and you're like, what's going to happen? Sometimes you want that security there, or you want to be able to target a slightly lower part of the therapeutic spectrum. So unfractionated does have a role, but I think low molecular weight is increasingly becoming the default. Is that your experience too, Cyrus?
It is, Nick, and I think those are excellent points, and I appreciate kind of underlining some of those instances where unfractionated heparin has historically been the go-to, but now as I said, the paradigm is shifting, and yes, that's certainly what I'm seeing as well. So moving on to perhaps one of the most debated pillars of PE treatment to some degree, anyway, would be pillar number 3, which is invasive management, and then kind of this concept of thrombolysis. And so there isn't a whole lot of equipoise when it comes to the quote unquote massive PE or the high risk PE, where a patient is in shock, actively arresting before your eyes. Those are patients for whom thrombolysis via tissue plasminogen activator, TPA, is warranted. There's a very strong indication for that. It's not quite as clear, however, when we're discussing patients with a kind of quote unquote submassive PE, or those that are intermediate high or even intermediate low risk patients. And so there have been some studies looking at that, but really the data is not cut and dry. So if you go back to 2002, the MAP-IT-3 trial was completed, and that looked at 256 patients with RV dysfunction or pulmonary hypertension based on echo findings and or right heart cath data. And in that group, 118 got heparin plus alteplase, while 138 received heparin plus placebo. And so again, we're talking RV dysfunction and PH, but no evidence of shock. So in that study, they looked at in-hospital death or clinical deterioration requiring escalation of treatment as being the primary outcome. Now, note that I said death or clinical deterioration, which in evidence-based medicine, we refer to that as a composite endpoint. We'll talk about that in a second. So in any event, they identified that in the treatment group, 11% of those individuals either died or had that clinical deterioration to which they refer. Versus in the control group, that would be the group receiving placebo plus heparin, 24.6% actually experienced the primary outcome. So that works out to a number needed to treat of 7.5. Nick, what do you think about that?
And so normally, right, if you look at that at just face value, that looks like a huge effect size. Obviously, everybody with RV dysfunction or pulmonary hypertension should be getting thrombolysis, right? Well, there's a catch, and you alluded to it beautifully.
Yeah, exactly. So the point here is that this was a composite endpoint. And so, one of those composite endpoints being this clinical deterioration, which could be defined in a number of ways. They talked about, the use of catecholamines or rescue thrombolysis. And so one could argue that the patients that are going to require an intervention, they're going to sort of declare themselves
They're going to
down
cross
the
over.
road. And so exactly, they're going to cross over. And so it does sort of muddy the waters to a certain extent. And this is underlined by the fact that mortality, which is sort of the like brass ring, if you will, and recognize that it's very difficult to prove mortality benefit in a lot of ICU studies and a lot of studies in general. But suffice to say, this brass ring was not significantly different between the groups. And mortality was actually relatively low. It was 3.4% versus 2.2% treatment versus placebo. It should also be noted that there was no fatal bleeding or cerebral bleeding noted in the patients who received alteplase. And in these folks, the alteplase dose was actually full dose TPA. It was 100 milligrams given over 2 hours. And then I'll also caveat this by saying 32 of those 138 control patients required rescue thrombolysis. And so that, again, speaks to that idea of the composite endpoint. I'll also kind of mention that interestingly in the study, they cite one major bleeding episode in the heparin plus alteplase group and 5 in the heparin plus placebo group, which seems very odd to me. And they don't really discuss that very well in the paper. So I don't know, Nick, any thoughts on that or any thoughts on what we've discussed so far?
Yeah, so you raised some great points there in talking about that paper. So I think, one important point to raise is that when we think about thrombolysis versus anticoagulation has some significant bleeding risks as well. So it's not like your risk is nothing versus something. Your risk is something versus maybe slightly more. And so I think that's an important level set, right? Remember that TPA has a biological half-life of minutes. So, the person is at risk of bleeding, but it's a very short risk, right? Whereas somebody who's on heparin for a while, they might have a non-trivial risk of bleeding just from that. And as we saw in this study, the control group had a lot of bleeding. Another point that I think, we need to mention is that when we're counseling patients about thrombolysis and we're talking to them about the risk of bleeding, we often will quote them a number like a 6% risk of intracranial hemorrhage. And that number comes from the stroke literature, which is a whole nother can of worms that we won't open today. But in that literature, people who had ischemic strokes were given TPA, and in some of those studies, about 6% developed an intracranial bleed. Now, that is not a proper comparator here. The people with strokes tend to be older. They tend to be more likely to have comorbid conditions like amyloid. And by the way, they also have stroke. They've had this big intracranial event, which can bleed secondarily. So when you tell somebody the risk of bleeding is 6% with alteplase, it's probably not accurate. It's probably much less than that. And in our case here, for a 45-year-old with no medical comorbidities, the risk of intracranial bleeding with alteplase is probably much, much lower than that. So I think it's important to always think about who was studied in each study and is that like your patient? And in this case, it's not.
Excellent. Yeah. Thank you, Nick, for highlighting some of those points. I think those are very, very important ones for our audience to take away. So a couple other studies that I wanted to talk about, but in the interest of time, I'll try to be a little more brief on these. So in 2013, we have the Moffitt trial. That one's commonly quoted. And so that's one that looked at patients with submassive PE and asked the question, does low-dose TPA reduce the incidence of pulmonary hypertension or recurrent PE when compared to anticoagulation alone? So again, we're not talking mortality here. We're talking pH and recurrence of PE. And so in that study, they identified that low-dose TPA plus anticoagulation reduced the incidence of pulmonary hypertension and of the composite outcome of pulmonary hypertension and or recurrent PE compared to anticoagulation alone. Again, there's that word composite outcome, or that term composite outcome. One kind of interesting thing, there are a couple interesting things I should say about this study. First off, they use a very unusual definition for PE. It's not really one that we use. So they referred to the moderate PE. I said submassive, but really in their paper, they use this term moderate PE, which is 70% involvement of thrombus in greater than or equal to 2 lobar segments, or either the left or the right main pulmonary arteries, or a high probability VQ scan plus 2 or more PE symptoms, which were things like chest pain, tachypnea, dyspnea, etc. So a little bit of an unusual definition for PE, which I think is kind of like, I don't know. To me, that raises a little bit of a red flag. Nick, what do you think?
Yeah, it's a red flag. I mean, I think this is an important study that actually probably changed practice a bit and popularized half-dose TPA. But you got to realize that this is a weird definition of PE. This is like a radiologist defining PE as opposed to an intensivist defining PE. And recall that in part 1 of this episode, we talked about how PE, the clot burden is actually not a great predictor of outcomes, but the effect of the clot, the hemodynamic effects, the effect on the right ventricle is. So it's a little bit weird that they're sort of fixating on clot burden instead of those other things, which frankly are pretty easy to measure. And that's how we defined submassive high-risk PE at the top.
Absolutely. Yeah, very odd indeed. And so this was a single center, 121 patients, so not a huge study. And like you said, Nick, the groups were randomized to receive half-dose TPA, which is 0.5 milligrams per kilogram, up to a max of 50 milligrams via bolus. Up to a max of 50 milligrams via bolus of 10 milligrams, followed by the remaining 40 milligrams administered over 2 hours, in addition to heparin. And then the patients were also placed, as I recall, on warfarin ultimately as their sort of long-term anticoagulant regimen. And they had pre and post echoes that were used to determine the presence of PE. Were used to determine the presence of pH and also to assess RV hemodynamics. And so, like I said, they looked at this composite outcome of pulmonary hypertension or pulmonary hypertension and recurrent PE. And the outcome favored the use of TPA with a shockingly low number needed to treat of 2. And, whenever I see a number needed to treat that low, it certainly, again, raises a little bit of a red flag because that's like less than penicillin in the setting of like a strep infection. So that's a bit odd. But then what's even kind of more interesting is that they had no significant bleeding complications at all, which is not really consistent with data either for heparin use or for TPA use, which in both instances you expect to see some degree of bleeding. So no significant bleeding complications at all seems a little bit odd to me. And then finally, kind of that mortality benefit that we often aspire to, that wasn't really there. And as I sort of alluded to, the sample size was pretty small. So I would say that it is a landmark study in the sense that it opened the door to kind of half dose TPA for non-massive PE, but there are certainly some concerns I have in regards to the study itself and how applicable it is. Before I move on, Nick, to the Pytho study, anything else you wanted to say before we do that?
I think, my takeaway from this study is not necessarily that half dose TPA is a great intervention, even though this study looks great. It's more that half dose TPA is a very safe intervention, that they gave it to a lot of people and none had serious side effects. So again, just disabuse ourselves of that 6% TPA intracranial hemorrhage risk and recognize that the true risk is probably well under 1%.
Excellent. That's an excellent takeaway, Nick. So, kind of as I alluded to, I wanted to talk about the 2014 Pytho trial. So this is another pretty commonly cited trial in the PE literature. And so in that study, they looked at patients with submassive PE being treated with unfractionated heparin, and asked the question whether the administration of tenecteplase reduces all-cause mortality or hemodynamic decompensation at 7 days when compared to placebo. So the first thing I would consider in this study is, we're talking 7 days. 7 days is pretty short term. And so, is this an intervention that's going to have a long-term benefit to a patient versus the potential risk of getting TPA? The study wasn't really designed to answer that question. But so with that in mind, we'll take a closer look at what they did here. So unlike the last study we discussed, this was a multi-center RCT. It was double-blinded. It was pretty large. There were over 1,000 patients in it. And within the two cohorts, there were 506 patients that got tenecteplase, and they received 30 to 50 milligrams IV via a push dose, as well as unfractionated heparin. And then there were about 500 that did not get any sort of TPA, but they got unfractionated heparin. And as far as inclusion criteria, they were looking at patients that had confirmed PE with evidence of RV dysfunction on echo and or CT, as well as that elevated troponin I or troponin T. So very much the sort of intermediate high risk PE patient that we were talking about earlier.
Exactly like our patient.
Exactly. Yeah, exactly like our patient. And so as I mentioned, so they were looking at all-cause mortality or hemodynamic decompensation. So again, a composite outcome at 7 days. And so they identified that composite outcome at 7 days occurred statistically more frequently in those patients that did not get tenecteplase. And so that works out to a number needed to treat of 33. Not surprisingly, all-cause mortality itself was not significant at 7 days. And I should correct myself, they did go ahead and look at 30 days and also saw that there was no significant difference there at 30 days. But hemodynamic decompensation at 7 days, very, very significant with a, and I say that colloquially, but it was significant with a p-value of 0.002, which to me demonstrates that this composite outcome was really pulled in large part by that element of hemodynamic decompensation.
And one quick point to raise here is that I don't think we're ever going to see a trial that demonstrates a mortality benefit in intermediate risk PE for one simple reason, which is that if somebody gets sick, they cross over and they get thrombolysis. And so, unless there's like significant delays in doing it, you would pretty much expect that everybody who needs TPA is going to get it later in the control group. And so you could look at that two ways. You could say like, well, why don't we just treat everybody like the control group? And then when people cross over, when they cross over. Or you could look at that and you could say, well, it's an unreasonable goal to expect a mortality benefit in these trials. The fact that many of them trend towards a mortality benefit is an encouraging sign. So just, it's one of the challenges of doing a study where when somebody crosses over, they get the intervention. Because it's going to be very hard to prove the intervention works when that's the way medical practice is.
Yep, that's all great points, Nick. And so to sort of finish our brief discussion on the Pytho trial, so unlike the Moffitt study, they actually did cite a bleeding risk and note that there was statistically more bleeding in those given tenecteplase, with also an increase in the risk of hemorrhagic stroke in that population.
Yeah. So Cyrus, can you summarize the literature? Is there anything you can point to that kind of ties this all together?
Yeah, Nick. So actually, in 2014, there was a study by Chatterjee et al. It was a 16-study meta-analysis in JAMA that looked at thrombolysis in PE. Actually, the title of it was Thrombolysis for Pulmonary Embolism and Risk of All-Cause Mortality, Major Bleeding, and Intracranial Hemorrhage, a meta-analysis. And so within that 16-study meta-analysis, there were 8 studies that included patients who were hemodynamically stable with RV dysfunction, so more of those submassive or intermediate risk type patients. They did receive a separate statistical analysis, so there is that to reference. But what was identified was in those that received TPA, mortality was 1.39% versus 2.92%. And similarly, in those that received TPA, there was an increased bleeding risk of 7.74% versus 2.25%. So based on that study and based on everything we discussed, Nick, any take-home points in regards to all of that?
Yeah, so I think the great thing about an analysis like this is it ties together many studies that individually were not able to show a mortality benefit, but in this meta-analysis, we did in fact see a mortality benefit. So it suggests that there is a change in a patient-centered outcome with thrombolysis in intermediate risk PE. Great. It also showed that there's an increased bleeding risk. And this this is kind of why it's great to have a multidisciplinary approach to this, because you have to weigh these two things and you have to think like, how can I individualize therapy for this particular patient, right? Are they somebody where I think they have a lot of residual clot burden and the next clot could kill them? Or do I think there's somebody who's pretty robust and they're at increased bleeding risk, so I really don't want to put them through this risk? So this is a situation where, if we summarize what we know, there is a benefit overall to thrombolysis and intermediate risk PE, but there's also an increased bleeding risk. And so, you got to weigh these two. And that's why it's helpful to sort of like have a individual approach for each patient.
Absolutely. And so a patient like the one that we've discussed here, a 45-year-old postoperative gentleman, so he falls into that kind of gray area as far as whether or not thrombolysis would be indicated. There are other options for intervening in a patient like this, specifically catheter-directed thrombolysis, which is, one of the newer interventions that's often discussed. We don't want to spend a whole lot of time going through that because we think it would be great fodder for a good pro-con episode in the future in and of itself. And really the data is not terribly compelling, but briefly, at least in my estimation, there's kind of two things we can tell based on some of that catheter-directed data and then the data that I discussed. So, we can probably get away with less TPA than we typically use. So we can probably achieve the same goal with less than 100 milligrams of TPA or 100 milligrams of alteplase. And whether that's half dose, quarter dose, or weight-based dosing, I don't think we know the answer definitively to that. Nick, what are your thoughts on that first point?
Yeah, so I think if you think about this pharmacologically, like it kind of makes sense. So when you're giving TPA in stroke, you're basically giving TPA to the entire body, and you're hoping that it goes to the brain, which is getting like 20% of the blood flow, right? And there you're hoping to like completely break down a thrombus to restore blood flow quickly to part of the brain that's ischemic, right? Compare that to the lungs, where first of all, they get 100% of the blood flow, right? It doesn't have to go to the brain. Every drop of blood is going to go through the lungs. And two, you actually don't need to completely lyse those thrombus. You really are just trying to improve the hemodynamics by breaking down some of that clot. And you can be patient. You can break down some now and let the heparin work. It's not like, we don't say that time is long, right? Like we do with brain. And so I think all of those are good arguments for why a lower dose may be sufficient. And presumably a lower dose has substantially lower bleeding risk too. So I think there probably is a sweet spot, half dose, maybe lower in the future.
Absolutely. And so like as I alluded to, the catheter-directed thrombolysis or CDT devices, those devices are giving far lower doses of TPA, and the idea there is that it's kind of quote unquote directed, whether it be physically directed or physically plus like ultrasonographically directed into the clot. Whether there's an element of voodoo there or whether it's really derived in hard science, I think that's another topic for discussion. But what the data does show, at least in regards to these devices, is that that there is an improvement in hemodynamics and pulmonary artery pressures and in RV dysfunction, but there is not a lot of convincing data to suggest that this translates into solid patient-centered outcomes, or certainly there's no, again, mortality benefit there that we can discuss. Recognizing the limitations of mortality benefits in the setting of these kind of discussions, but the fact remains that there just isn't a preponderance of data to help us make the decision. There are small case studies. There's several of them that I looked at, and we'll make sure that those are in the show notes, which in conjunction with the CDT data suggests, again, as Nick kind of underlined, that low-dose TPA, 50 milligrams of alteplase, maybe lower, whatever, could be a very reasonable approach, especially for those submassive PE patients or those intermediate high-risk PE patients with concern for decompensation. So to kind of finish this element of the discussion, I would say that like Nick pointed out, these decisions should not be made in a vacuum. If you have a PE response team that you can work with, that would be ideal. And again, every patient is an N of 1. So you really do need to consider their bleeding risk and consider their history. And maybe that's a patient for whom maybe that kind of more worrisome patient is someone who you try quarter dose TPA in and kind of reassess and see if that was enough to help improve their hemodynamics.
Yeah, so I think thinking about this patient in this case, youngish, 45-year-old, few comorbidities, who had a recent surgery. So they presumably have lower risk of intracranial bleeding, but some risk of bleeding, from this surgery they had on their legs a week ago. So this is a situation where, you might say this is a person where I'll just manage them conservatively. I'll put them in the ICU or step down unit. And if they get sicker, I'll give them, quarter dose lytics, in the future. Another option, depending on where you are, if you're at a facility that has a cath lab that can, spring into action for this, and they think that this clot is, unilateral and it's really amenable to catheter-directed thrombolysis, I think that would be a great option in this case, because that will presumably reduce his bleeding risk still further. It'll let us treat this before there's a risk of decompensation. And so I think that would be a great option as well. One thing that can help sort of tilt the scales a little bit is understanding what their clot burden is. So often getting duplex studies and seeing how much clot there is in their legs can help you figure this out. There's a big difference between somebody who's got a PE and they basically have embolized all the clot in their leg versus somebody who's had a PE, they're tenuous, and there's a lot more clot just waiting to break off. And I think that sometimes that is what pushes me towards being more aggressive about recommending catheter-directed thrombolysis or low-dose systemic thrombolysis. If I'm worried that there's sort of a sword of Damocles in their deep veins waiting to fall.
Beautiful. Yeah. And Nick, I think we discussed this in pre-recording, but definitely would be a fun episode, maybe for a pro-con debate, and get some guests on the show who can argue their approach, versus other approaches, and kind of just, I think that'd be fun and educational. So hopefully we can do that in the future.
Yeah, that sounds great.
So, we've talked about several of the pillars of PE treatment. We've talked about oxygenation. We've talked about anticoagulation and thrombolysis or forms of thrombectomy. The one thing we haven't really talked about yet are hemodynamics. We haven't really hammered that home yet. And so let's cover this as we advance the case. So this patient ends up being diagnosed with an intermediate high-risk PE, and anticoagulation is started via a heparin protocol. He's administered to the hospital's progressive care unit, and 12 hours later, you're paged as the intensivist on call to the bedside. The patient is now hypotensive to 85/54, tachycardic to 122, and hypoxemic to 92% on 15 liters non-rebreather. You do a quick bedside ultrasound, and it confirms RV dilation. We'll go ahead and say you see some of those findings we discussed in episode 1 that further suggest RV dysfunction. And you do a quick chart check. The patient's not febrile. They haven't been started on any new agents. They're not bleeding anywhere. And so you're pretty certain that the shock state that is developing is related to their PE. The patient also looks like they're having a hard time breathing. They just don't look good, Nick. How does this change management, and do we need to up the ante?
Yeah. So, first off, let's think about both what is going to be the definitive treatment for this and what's the immediate treatment. So the definitive treatment is if they have not received thrombolysis, now this person is in massive PE territory, they need thrombolysis of some sort. If they've gotten a quarter dose or half dose, I might give them another quarter or another half. And order that right now. That means that in like 20 minutes, it'll come. If this person, is a candidate for some other therapy, maybe get the ball rolling on that. Generally, when somebody is sick like this, though, I don't really want to activate the cath lab and bring them down there. I'd rather give them, half dose systemic lytics right now at the bedside, or full doses right now at the bedside. Let's talk about their shock. So this person is clearly in obstructive shock due to a PE. Probably what happened, in fact, was some of that residual clot that we were just worrying about broke off and went to their lungs. And now their RV, which was tenuous before, is now very, very unhappy. So what can we do? Well, there's often an instinct to bolus when you see hypotension. And you got to be careful about this. On one hand, the failing RV has high pressures and needs higher filling pressures. So increasing preload could help a little bit, but it could also hurt. And giving a lot of volume could stress that RV out even more. It could make that volume overload even worse. And it could push you down that RV death spiral we talked about. So in general, in somebody like this, I'm going to give them a little bit of fluid, 250 mils, maybe 500 at most, and no more. This is not somebody to give liters and liters to. This is somebody who's hypotensive. They're not perfusing their tissues. We need to start vasopressors. The question is which one? And I think there's some clear wrong choices, and there's some better choices. So you're never wrong if you pick norepi in this case. I often will start with vasopressin. The idea here is that vasopressin doesn't increase your pulmonary vascular resistance like at all. Norepi doesn't really either. So those are both good choices. What I would definitely avoid is I would avoid vasopressors that raise your PVR. And so a couple examples of that are like phenylephrine and dopamine. Hopefully you're not using a lot of those as your first line pressors, but definitely don't use those in this case.
Excellent. So now moving on, we talked pressors. I think that's really important. As you mentioned, Nick, you talked about thrombolysis. So this is a case where that intermediate high risk PE has really blossomed or degraded, I should say, into a full-on massive PE, and thus clearly thrombolysis is indicated. And so in a patient like this, just to be very granular, my preference would be to use alteplase, 100 milligrams. There's evidence to support 100 milligrams over 2 hours versus 15 milligrams over 15 minutes, versus 50 milligrams over 15 minutes, followed by the remaining 50 milligrams over the next hour and 45. And so in this case, given the rapid decompensation, I would probably tend towards the bolus dose in order to get more drug on board faster. Now, once again, could I go with a lower dose? Probably. Again, 100% of blood flow is going to the lungs versus 20% that goes to the brain. We're extrapolating from stroke literature, et cetera, et cetera. The reality is we also have to recognize, this is the data we have is the data we have, and it may be difficult to defend a decision to use a lower dose in the absence of any sort of complicating factors. So I think going with the tried and true 100 milligram dose would be appropriate. That's what I would do. Furthermore, the evidence in these circumstances for full dose TPA supports its use even given the concurrent anticoagulation therapy. So just because they're on anticoagulation, you don't really need to be too terribly worried about that. Yes, they may be a little bit more likely to bleed, but at the end of the day, bleeding versus dying, we're gonna take that risk. As far as what do you do with anticoagulation during that time of providing the TPA, there isn't really a standard practice, at least as far as my literature search revealed. Some folks will just stop the drip. Other folks will continue it. I don't really think that there's necessarily a right or wrong answer, unless your answer is to not give any sort of thrombolysis, in which case you are definitively wrong. So that being said, Nick, we've got TPA running. We've talked peri-arrest resuscitation. Unfortunately, we've got a guy who presumably has a significant VQ mismatch, and he's really working to breathe. His VBG is showing a PCO2 of 55, despite the tachypnea. He looks bad. We're worried about this guy. Do you mind, Nick, reaching back to our prior discussion of the physiologically difficult airway and walking us through, once again, how you would approach a patient like this?
Yeah, so this is a scary situation, and this is something we talked about in the prior episode on the physiologically difficult airway. So for more of a discussion listeners should go back to that. But I think there's a couple of key points we need to emphasize about PE. So remember that what's going on here is his RV is failing because his PVR is too high, because there's a lot of clot burden in his lungs. And remember that there are several other factors that are going to exacerbate that PCR. So hypoxemia, hypercarbia, and acidosis are all going to make that PCR worse. So one of the things that we need to be really mindful of is to avoid those things getting worse when we intubate, or this person could code. The other thing that we need to be mindful of is that going on to positive pressure is going to reduce his preload, and he may be very preload dependent because of those high right-sided pressures. Induction in cases like this is going to be tricky. It's always tricky when somebody is starting off hypotensive, but in cases like this, it's especially tricky. This is a situation where I'd probably have a bolus ready to go, but again, a small bolus. I don't want to overdo it. I want to have pressors in line and push dose pressures as well. It's always better to have like your vasopressin and norepi running, and then you can titrate them, than to have to start them. I'm also going to think about what can I do to proactively lower his PA pressures. So for example, like if I can throw high flow nasal cannula on under a non-rebreather and run inhaled epoprostenol through that, that might actually be a nice way to stabilize him a little bit. As far as how to intubate him, this is a situation where I would love to think about putting a non-rebreather on him. Put a non-invasive mask on him and try to ventilate him adequately to blow off some of that CO2 and prevent his hypercarbia and acidosis from contributing to a higher PVR. So this might be something where, I get a lot of stuff ready. I try non-invasive to sort of stabilize things with a plan that I'm going to basically keep that non-invasive mask on until my meds are at full effect, and then intubate him. Cyrus, what do you have to add to that?
Yeah, I think all that sounds great, and that's really how I'd approach the patient too. I think the one other thing I'll say is that in a pure PE patient who is suffering from a respiratory collapse, there's probably not a lot of benefit other than bragging rights, perhaps, of landing an 8.5 versus a 7.5 or even a 7.0 ET tube if you're worried that the airway is going to be tight. And so the reason I bring that up is it's often, maybe it saves you a split second, but that can matter in a patient who is this tenuous. And so, since we don't anticipate needing to do therapeutic bronchoscopy right away or something along those lines, I would recommend to our audience to just consider maybe going with a smaller, more easily placed endotracheal tube in a patient like this, rather than going for the big boy when you don't necessarily need it.
Absolutely. And I think, this is a situation where like I love teaching people airways. This is not a situation where you want somebody inexperienced to do the airway. This is a situation where seconds are going to matter. You want your best person to attempt the airway first. It's also a situation, by the way, where you want to make sure to be very hemodynamically gentle with your induction agents. Ketamine comes to mind. Etomidate would be okay too. Definitely would not give this person propofol.
Excellent points, Nick. So we had kind of alluded to this. We've danced around this concept a little bit as far as pulmonary vasodilators. So I want to take an opportunity now to double click on that and talk a little bit about them, because they're useful both in the pre-intubation setting, the post-intubation setting, in patients that aren't intubated at all. And so, generally they're great agents, especially when given via the inhaled form, because they're going to preferentially treat the lungs. So we worry about any sort of vasodilator in a shock state, obviously. But the nice thing about these agents is that they are directed to the pulmonary vasculature. They're going to reduce RV afterload without causing that systemic vasodilation, and they're going to improve VQ matching and improve oxygenation in patients like this. So that's tremendously important, and these can be a really great asset in your very sick to crashing PE patient. In my experience, and Nick, I'm curious to hear what you guys do in your shop, but we usually will use inhaled epoprostenol, which is a prostacyclin that causes vascular smooth muscle dilation via cyclic AMP-mediated mechanism, versus inhaled nitric oxide, which causes vasodilation of the pulmonary vasculature via a cyclic GMP-mediated mechanism, or potentially using them in unison if you really want the double whammy, if you will. as far as nitric oxide goes, there are some concerns regarding using it in the setting of pregnancy, although there are also some case studies that demonstrate its safety in pregnant patients. And so generally, at least in my shop, if someone's on nitric, there are signs saying, "Hey, if you're a pregnant, staff member, stay away." We usually don't use that agent in patients that are pregnant or potentially pregnant, and so those are cases where epoprostenol would be perhaps a better option. And I'll also say that in my experience, nitric oxide is pretty pricey. It's a pretty expensive agent. And most of the places I practice, epoprostenol is less expensive. And so you're certainly, institutionally encouraged to use that less expensive agent, assuming it is working for that patient based upon kind of similar efficacy. Nick, do you want to chime in here?
Yeah, that's exactly what my experience has been. We preferentially use inhaled EPO. I think it has a good side effect profile. It's cheaper. There's a lot of advantages to it. The one place where I think there's a really compelling argument for inhaled nitric oxide in adults is in the cath lab when you're doing vasoreactivity testing, but that's a whole different story. In general,
Yep.
if you're choosing to have one agent in your ICU, I would just have inhaled EPO. Personally, I've never done the combination before. I actually have to read about that and see if there's any there. Theoretically, I can see how cyclic AMP plus cyclic GMP, there could be synergy between those pathways, but I've never seen it. I've never read about it. I don't know.
Yeah, Nick, I haven't done it myself, but anecdotally, I've heard of folks using the two together in patients that are suspected of having really high PVRs, and it's worked out. So probably something that we should do a little bit more digging on before we really recommend it. But again, anecdotally, something that you could consider. And so let's continue this discussion and talk a little bit about thrombectomy. So we haven't specifically talked about mechanical thrombectomy or surgical intervention. So let's suppose that you go to the bedside, you assess this patient, and you see clot in transit. Nick, what are we going to do with that?
So clot in transit is one of the absolute scariest things you can ever see on point of care ultrasound. What this means is that you put the probe on, and in the right atrium or right ventricle, I suppose, you see a clot bouncing around in there, right? And this really is like that sword of Damocles. Like this is disaster waiting to happen. This is a clot that, like, if it manages to make it through some valves, is going to go to the pulmonary circulation, and often that will be fatal. So this is a rare, serious situation that we need to treat aggressively. Traditionally, clot in transit is a clear-cut indication for surgical embolectomy. And for people who are hemodynamically unstable with a clot in transit, I think that's very clear. I think if you're thinking about somebody who, if you're thinking about, so let's assume, actually, let's back up and say that, like, in somebody who's stable with clot in transit, I think there are people who would argue that you can do clot retrieval. I don't think there's very much literature for this, but there are some case reports. So I think that's something that kind of depends on what are your institutional strengths. If you have, a cath lab immediately available and you don't have surgical options available, maybe that's something to consider. I think, in general, this is a case where I personally would advocate for surgery and somebody who is a surgical candidate. While we're talking about thrombectomy, or we're talking about surgery in general, one other situation where I think there's a good argument to be made for surgical embolectomy is patients who are unstable enough to need ECMO. If they're going to go through the risks of being cannulated, putting those catheters in, and going on bypass, the added risk of surgery is somewhat smaller, and this could potentially fix the cause of their hemodynamic collapse right away. I guess one other thing we should talk about is that surgical embolectomy makes sense when there's a lot of bilateral clot burden that the surgeon feels like they can remove. It probably doesn't make as much sense when that clot burden is really peripheral and it's going to be really hard for your surgeon to get them out. But it probably does make sense when they feel like they can give a really good result really quickly in somebody who's really unstable. One argument that you sometimes hear here is that removing this clot will help long-term outcomes. It'll prevent sequela like developing CTEPH, chronic thromboembolic pulmonary hypertension. I think this is kind of bogus, to be honest. Two reasons for this. First of all, chronic thromboembolic pulmonary hypertension is chronic. It's usually not a result of one episode. It's usually a result of many episodes where clots are becoming endothelialized. The second thing is that it's actually very rare for somebody to develop CTEPH after an acute PE. If you look at the studies, only about 0.5 to maybe at most 5% of patients who have a acute PE will go on to develop CTEPH. So, I could say that if I was the patient, I would much rather have somebody put a catheter in my femoral vein than undergo a sternotomy with all the attendant risks of anesthesia, bypass, secondary infection. But there are patients, like a patient with clot in transit or a patient needing ECMO, or maybe very specific clot burden cases where surgical embolectomy makes sense. That's a longer conversation. And again, a lot of this comes down to what services are available at your hospital, what services are available when you need it. I feel kind of spoiled. I work with some really great CT surgeons who I'm pretty sure only need about 8 minutes of sleep a night. So they're available like in seconds if we decide to go this route. Now, I sort of alluded to this, but Cyrus, before we close out, we should probably talk about ECMO, both because it's a viable treatment and bridge in some cases, and also because, frankly, we love talking about ECMO. So what are your thoughts on ECMO in PE?
Yeah, Nick, you hit the nail on the head. And first, thank you for that discussion that you led us through in regards to thrombectomy. I think it's an important concept, and it's definitely a complicated and nuanced one, as we have alluded to several times now. We're definitely going to talk ECMO on at least a few dedicated episodes. I know some of our team members are excited to talk about that as well, but we can, I think, briefly touch on it here. I'll try to provide a little bit of background for folks that aren't as familiar with ECMO. So the nice thing here is it can provide pulmonary or cardiopulmonary support relatively quickly. And it can really save a patient like this. The key to remember is in, again, painting with very broad strokes, there are two flavors of ECMO. There's VV or veno-venous ECMO, which stands for extracorporeal membrane oxygenation, I should say. So there's veno-venous ECMO, and then there's veno-arterial ECMO. And so in a patient like this, veno-venous ECMO or VV ECMO really bypasses the lungs and therefore is not the right answer because we're not providing any sort of cardiac support. And so what a patient like this really needs would be cardiopulmonary support with something like with VA ECMO or again, veno-arterial ECMO. In my experience with PE patients that end up on ECMO, a lot of times it's used in something called eCPR. So basically, these are patients who have arrested, and during the resuscitation, we're getting them ready for ECMO. We're actually cannulating them during the resuscitation, knowing that they are at very, very high risk for decompensation again, even after ROSC is achieved. And you can kind of peripherally put in these large catheters, one in the vein, one in the artery, to support both the heart and the lungs and buy you time to go for thrombectomy, let your lytics work a little bit longer, whatever it is that you need to do. Overall, I think that, if the question is, who is a good candidate for ECMO with a PE? I would say it's either going to be those that arrest in the setting of PE or those that have a rapidly uptrending pressure requirement in the setting of PE when you're thinking, okay, maybe this person hasn't quite arrested, but it looks like they're moving in that direction and it looks like we need to get ready for VA ECMO, assuming, again, that service is available at your institution. What say you, Dr. Mark? How do you handle this?
Yeah, I agree with what you said. I mean, so VA ECMO is a rapid, reliable form of mechanical circulatory support that's going to greatly decrease RV volume overload and support systemic perfusion. So in short, it's the perfect solution for this. The problem is that it also has significant bleeding risks. There's risks, catheter placement, there's risks of limb ischemia, et cetera. So it's not without risk. But in somebody who is in worsening obstructive shock due to PE, I think it's definitely indicated. I think the challenge is not recognizing when it is indicated. I think the challenge is recognizing when it might be indicated, right? And so if somebody is like crumping before your eyes and, you're like, we have to crash them onto ECMO, that's great. And, you should absolutely go for it. But the better time to think about it was what happens if this person gets sicker? Like when we're making a decision to admit them or not, having a discussion about this. And so one of the things that I always like to bring up in PERT meetings is for sick patients is, would this person be a candidate for ECMO? And that allows us to plan ahead. So first of all, are they in the right place physically, right? They should be in, the cardiac ICU as opposed to in another unit. Second of all, it might change our choice of what lines to place. So if this is a person who, let's say, is going to the cath lab for a procedure, I might ask them to leave in their sheaths. I might place a femoral A line in them before lytics. That way we have we've already cannulated the vessel. So all we have to do is just upsize over a wire, and we can put them on pump very quickly. Now, the thing about VA ECMO in PE is it's actually a great situation for it, because it's an acutely reversible situation where we often think if we could only support this person for a few hours for our lytics to work, for our thrombolysis to work, for our anticoagulation to work, they will survive. And so I think it's great. I've seen some absolute saves. I think the challenge with ECMO in general, and especially in this case, is patient selection. You want to identify patients who are good candidates for it. And so in a future episode, we can talk about what that means more in depth. But I think this patient, 45-year-old with no medical history, who recently had surgery, is an ideal candidate for it. If this person is decompensating, this is somebody I would advocate hard for ECMO in. So Cyrus, we've talked about basically all things PE. Do you want to kind of summarize where we are, kind of give us a closeout on the case?
Yeah, absolutely, Nick. So as Dwight Eisenhower said, in preparing for battle, I've always found that plans are useless, but planning is indispensable. So, you can have the best plans possible for a PE patient, but when that patient gets sick and when the rubber meets the road, sometimes it's just the exercise and planning and having the skills necessary to come up with a plan. That's what really saves you in the end. PE can be a lot like a battle, so to speak. And so this patient had a difficult course. Everything didn't really go according to plan. Fortunately, our planning made for the best possible outcome. So in this case, we were able to administer TPA safely. We were able to resume anticoagulation and actually transition this patient to an oral anticoagulant. They did get intubated, as we discussed, but they were only intubated for a few days, during which point the pressor requirement disappeared, likely due to the effects of TPA and then the continued effects of heparin. So fortunately, they did not need any sort of thrombectomy. They lucked out in that regard, and they did not need to be put on ECMO, so good for them. I'll say that on discharge, the patient unfortunately had some evidence of persistent right ventricular dysfunction, but did say they felt a heck of a lot better than when we met him prior to his ICU transfer. So with all of that said, with this happy ending that we can pat ourselves on the back about, Nick, do you want to close out this behemoth of an episode with your key takeaway points for PE management?
Absolutely. So I think, the first key takeaway is, remember that PE is both common and commonly missed. One mantra I like in the ICU is, could this be a PE? Try to remember that this is a common cause of preventable hospital deaths. So remember to consider it. The second thing that I'd emphasize is, remember the physiology of PE. Remember that it's not an oxygenation problem so much as a RV afterload problem, and think about all the things that you can do to optimize that and prevent that RV death spiral. Third, I would just remind people that, patients with PE span this incredibly wide spectrum from asymptomatic to super duper sick. And that state can change dynamically. These are patients where it's useful to have scoring systems so that you can get an objective measure of how sick they likely are as opposed to how sick they look. And it's also important to reevaluate these patients. They can turn on a dime. In general, for anticoagulation, low molecular weight heparin is best, but there are maybe some times when unfractionated is better. And for all patients, but especially for sick patients, I think it's really valuable to have a multidisciplinary PERT team to help decide about some of these complex questions like thrombolysis versus intervention, ECMO, et cetera.
Nick, thanks for that summary. And really to our audience, thank you for listening to us. This has been a huge episode, and it's a two-parter. So I know there's just a ton of content here that we went through. We like to try to keep our episodes a little bit more svelte when able. But really, there's just so much important content that you guys need to appreciate when it comes to PE management. And I hope you guys recognize that. And so now that that's all been done and dusted, we've come to the part of our show where we like to say thanks. Thanks to everyone who's left us reviews, comments, or given us a shout out on social media. We really appreciate it. We love to engage you guys. The suggestions are helpful. The feedback is great. So thank you. If you want to continue to engage us, or if you haven't reached out yet, but you're interested in doing so, you can tweet us at Critical Care Time, or individually at Nick M. Mark or at Askins_Razor. Be sure to subscribe to the podcast, give us a like, and please leave us one of those 5-star ratings because it means a ton to us. It helps us get the message out far and wide.
We'd also like to say a big thanks to our sponsor, C-Star Medical. We're very grateful that this episode, like all of season 1 of Critical Care Time, is sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in AKI and sepsis. Check out their website, cstarmedical.com, to learn more. That's SEASTARMEDICAL, C-Star Medical.
And before we go, we would like to thank the incredible members of our podcast team, which includes the great folks over in Australia. That's Podpaste. They do our production. They are wonderful. We are so grateful to have them.
They fix all the errors we make when we talk over each other or whatever, like I'm doing right now.
They do. They fix all the errors. They cut out all the swear words, etc. So we really appreciate that. I'm sure our audience does too.
That's right. This podcast wouldn't be PG-13 without them.
That's right. And last but not least, our awesome theme music. We thank Kurt Belknap for that. We're very grateful for his expertise in producing that little ditty that you're hopefully hearing right now. And then lastly, this podcast and all related media, including but not limited to animations, graphics, and videos, are the property of Critical Care Time. Please share and use our content. We just ask that you cite your sources.
And finally, time for disclaimers. The views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. With that, I'm Dr. Nick Mark. Thanks again for listening, everybody.
And I'm Dr. Cyrus Askin. So long. See you next time.